Good afternoon, everyone. So, I'll be discussing how to get the right patient for your first case. So, always the aim of a study of a surgery during our inexperienced stage is to have a safe surgery more than a perfect surgery. So, we are not concerned about the actual visual outcome, but we need a safe and a good surgery. So, we must be ready to learn, unlearn, and relearn of what we have already done. So, always go by the book. That is, never miss or skip a step. Don't take any shortcuts. So, first important thing is history taking and the systemic examination. Always select a cooperative patient. So, the question is, how do you know whether the patient is cooperative? My sir used to say, when you talk to the patient in an OPD, if the patient talks more and you listen, that means the patient is not cooperative. If you speak more and the patient listens, that means you have a good patient. So the age group that we prefer is between 50 to 55 years. Ideal case. That is less than 45, they are younger, they are more concerned about the complications, they are more apprehensive. If they are more than 60, they are harder cataracts, so it will be a little bit difficult for a beginner. And select people who have non-demanding jobs. That is, CAM patients who are ready to do a free surgery, probably a female that doesn't have to go out, make a living. And always ask about the comorbidities. That is, choose a patient who can handle a prolonged surgery. Your initial surgeries are going to take about 45 minutes to 1 hour. So you need patients who are uh, cooperative. They'll lie down for you. So rule out all the uncontrolled diabetic, hypertensive people, any patient with a cardiac problem, any history of stroke. Make sure they have stopped all their anticoagulants. Any psychiatric illness patients, any patients on tamsulosin that can give you a floppy iris during surgery. Always rule out local infections. Look at the lid, look at their tooth, look at their foot, because all these are common places for ulcers and infections. And check if they can lie supine. That is, when you do a pre or post scan, you can just put a drape on their face and check if they can tolerate a drape and lie supine for almost 45 minutes. So, any asthmatics, any claustrophobics, patients with severe scoliosis who can't lie down straight supine, any patient with severe head nodding, Parkinson's patients, just rule out, don't take those patients. Also, when you make the patient lie down, you can also access the AC depth. Sometimes the lens will fall back and give you a little more deeper AC even, compared to when the patient is on the slit lamp and sitting. And any frontal bossing, these will give you a little bit difficult in handling and actually going into the anterior chamber. Always take a detailed ocular examination. Please avoid one-eyed patients. We don't want people to with one-eyed or low vision patients to get operated from us. The next one, any history of trauma. You have to ask for it, otherwise they will not tell you. Any previous eye surgeries like a vitreoretinal surgery, a glaucoma surgery, any previous cornea surgeries, all that will make it difficult for you to do your cataract surgery. History of uveitis is very important because intraocular recurrent infections, any iritis, uveitis, will have complications post-op because this is a prolonged surgery. You can handle the iris, you might touch the iris. So we don't want a chronic iritis patient post-op. Next, any high myopes, high hypermetropes, even high astigmatism, better to avoid. Complicated cataract like secondary to a trauma, secondary to iritis, all this we need to avoid. We cannot predict how the eye will behave once you open the eye. Always check for the fellow eye. As I already told, one-eyed people just avoid. Check for their surgery notes. See if there is any signs of iris chafing, any PCR had occurred, there is serious intra-op complications like iris prolapse, and what type of IOL has been placed, like a 3-piece, an iris claw, or an AZ IOL. So we expect the same complications in the eye that we are going to operate also. Always do a detailed adnexal examination, check for the ducts, check for the intraocular pressure, check if there's a deep eye socket, if there is frontal bossing, look for lid swellings. We need to evert the lid and look for it, only then we'll get it. If there is severe MGD, squeeze and flush it out, give topical steroid antibiotic ointments, give a course of oral antibiotic, and only then take for surgery. Then always do a detailed dilated slit lamp examination. You need to see the patient dilated and not the sister who is giving you the case. Check for the cornea. If there is severe dry eye scarring, check for the AC. If it's shallow, if there is a post-EAC PI, that patient might have an iris prolapse because it is a floppy iris. Then iris also you have to check for pseudo exfoliation. Don't take pseudo exfoliation patients. Even if on a sitting position on the slit lamp there is no phacodonosis, but the zonules might be weak. Once you enter the anterior chamber, you start your excess, the lens and the bag might start to shake. Rule out non-dilating pupils, posterior cynic, any floppy iris. Cataract, don't go for soft or too hard cataracts. Check for phacodonosis. Check for phacodonosis and avoid a PPC. Always ensure you have good local anesthesia. A well, soft, anesthetized eye is the best option. You have to wait for 20 minutes after the block before you start your case. Just blocking and then shifting the patient, the eye will be hard. Always drape well so that all the lid is away from the field. Avoid tight lid speculums. The globe will become hard and the intraocular pressure will be high. The microscope settings also, do your IPD, know your IPD before the surgery, set it and always neutralize the optics of the eyepiece. Illumination, you have to know how to put it in a bright, how to do a retro illumination. You have to know your microscope. The stool height, that will help in the depth perception. You need to know the foot pedal adjustments like how to up and down the focus, how to zoom in and zoom out. And always check your probes, whether the machines are working before you start the surgery. As you know already, you should know your instruments. They should be sharp, not blunt and already used ones. You should have that pen holding technique you must know. Keep ready all the ones that are needed to manage a complication like venas, iris repositors, sutures, vitrectors. And always keep talking to your patient when you do the surgery. That will help the patient relax. Also, it will help you to relax. And explain the completion of steps like, okay, I've finished the cataract extraction and I'll put the IOL. It's just going to get over. I'll finish it in 1 minute. The patient is also reassured. Always go by the book. Do not skip any of the steps. Always stay in the capsule. We need an adequate capsular excess of 5.5 to 6.5 mm. Always follow one mentor. You stick on to one person's teachings. Don't follow everyone who talks until gives you advice. Video recording already has been discussed by Dr. Aki. And always keep help in handy. Don't be overconfident. Keep your mentor with you. Just trust your trainer. Listen to your trainer. And do not hesitate to stop and withdraw if the things go wrong. If the trainer tells you to stop, that means he knows it's going to go wrong. Just stop. So this is the ideal first case. An age between 50 to 55 years. There's no history of trauma or surgery. The IOP is normal. A patient is cooperative. There is no deep socket or frontal bossing. He's not a high myope, hypermetrop or astigmatic patient. You have a good pupillary dilatation, grade of nuclear sclerosis 2 to 3, and a well anesthetized eye. Thank you.